Okay, good morning. Welcome to everybody. My name is Jenna Sistad and I am with the Ocean Monmouth Health Alliance. Today you are joining us for our Health to Hold webinar series. This is something we do monthly as part of our coalition work in Monmouth and Ocean County to help reduce the cancer and chronic disease burden. We are joined by many partners each month to try and help us create a unique message and to get the word out about the different partner sites that we work with. Today, we are happy to have the Parker Family Health Center with us. They will not only be sharing some information about the services that they provide, but to help us raise awareness about Colorectal Cancer Month. So without further ado, I would like to introduce Susie Dyer, her team, as well as Dr. Lisa Herkis. Thank you for being with us.
Thanks, Jenna. Thanks for having us. So I'm Susie Dyer. I'm the Executive Director at Parker Family Health Center, and I'm here with Dr. Lisa Herkis, our Associate Medical Director, as well as Maggie Clifford, who runs our clinic, and Sonia Guandike, who also handles all of our referrals and the SEED program. So for those of you who don't know about Parker Family Health Center, the mission of Parker Family Health Center is to provide free health care to the uninsured of Monmouth County. And we've been doing that for 23 years. Currently, 36,000 residents of Monmouth County are uninsured. In order to qualify, there are 3 requirements for patient eligibility at Parker. The first is you have to be a resident of Monmouth County. The second, you have to be at or below 300% of the federal poverty level. And this year, they actually raised the federal poverty level. And it is $43,740 for a single person, and you can read for a family of 4. And you have to be without medical insurance. Most of our patients, however, are probably around 150% of the federal poverty level. We are located right in Red Bank, a walking distance from the train or bus station. And we also provide for those of you, those patients who don't have transportation or transportation is a challenge, we provide Uber Health. We offer that to our patients at no cost to the patient. And now I'm going to turn it over to Lisa.
Oh, thank you very much. It's a pleasure to be here today. I'd like to be pretty informal about this talk and just give you some highlights. I've been in practice for about 30 years, and in the past 30 years, we've seen tremendous strides in colon cancer detection and treatment. Anecdotally, I'll tell you that my first year or 2 in practice, I was at a multi-specialty group, and I had 5 young women diagnosed with colorectal cancer. 4 of the 5 were in their 50s, 1 was in their 60s, and 4 of the 5 came to me with the same complaint, which was tiredness and shortness of breath. No one told me they had any bowel habit changes. The older woman told me she was more constipated. I did a physical exam. I found blood in the stools. We sent them for blood work. They were profoundly anemic. Unfortunately, 4 of the 5, actually all 5 were advanced at diagnosis, and only 1 lived to 5 years. After diagnosis, following surgery, chemo, very aggressive treatments. So I think we've really come a long way in identifying and treating colon cancer, as well as destigmatizing colon cancer. I think we probably all remember Katie Couric's colonoscopy on NBC. I think that was revolutionary because colon cancer has been a dirty secret. No one wants to say anything about the colon or the rectum. Breast cancer can be cool, ovarian cancer can be cool, even lung cancer can be cool with Yul Brenner's commercial, but colon cancer has not been very cool. Notably, we've had a number of celebrities who've been diagnosed and died from colon cancer, and I think that's helped tremendously. Of those, there's Chad Boseman, who died 2 years ago, Kirstie Alley, who just died, Charles Schultz, Elizabeth Montgomery Bewitched, and Audrey Hepburn, and I'm sure I'm missing quite a few. But I think those 4 or 5 things alone have been really helpful in destigmatizing colon cancer. So with that being said, let's go ahead and start. Have the next slide, Susie. And why is it important? Colon cancer is taking off. It's currently the 4th most common cancer detected in the US in the past year. It makes up 8% of new cancers, followed by breast. It follows breast, 15%, prostate cancer, 14%, and lung cancer is 12%. The remainder are the combination of all cancers, including the blood cancers. Unfortunately, colon cancer has moved up in popularity in terms of being a lethal cancer. It is now the 2nd most common cause of cancer deaths in the US, after lung, followed by pancreas and breast. Okay, next slide, please. Unfortunately, in the past year, we had 151,000 new cases of colorectal cancer, and 18,000 of these cases were identified in people younger than 50 years of age. And I can point to my own history in medicine where we had a young guy, he was only 26 years old, diagnosed with colon cancer, advanced at diagnosis and died pretty quickly, a pretty terrible death. We also had numerous other patients who had it. I had a different kind of background. I was in private practice and then taught at the hospital at Overlook Medical Center. So we got to see quite a diverse population. The number of deaths in the US were 52,580 in the last year. Now, who gets colon cancer? Anyone can get colon cancer. But overall, Black men and Black females have higher incidence and higher mortalities than other racial groups. Next slide, please. And for those of you who are not familiar with the colon, this is our colon. The colon starts at the very bottom on the left at the cecum, and that's where the small bowel joins up. It goes up the ascending colon, across the transverse colon, then the descending colon. The sigmoid colon is an S-shaped part of the colon and leads into the rectum. And you can develop cancer, colorectal cancer, in any part of the colon. Next slide, please. So what do we do about colon cancer? What are our risks for colon cancer? Number 1, age. We can't change how old we are. Inflammatory bowel disease. Patients who have ulcerative colitis and Crohn's disease are at significantly increased risk of colon cancer, and many of them have been advised to undergo total colectomy, and those who don't, unfortunately, often develop colon cancer. A personal or family history of colon cancer. If you personally have had colon cancer, you're at greater risk for recurrence. If immediate members of your family, mother, father, brother, sister, children, first-degree relatives, you're also at increased risk of colon cancer. There are some genetic syndromes. Oh, can you go back for a second? Familial adenomas, polyposis FAP, and as well as the Lynch syndrome, which predispose you to colon cancer. So in some patients, when they present with a history of colon cancer, newly diagnosed, and you do a family history, and you find many of the family members have had either colon cancer or other cancers, it's important to send them for genetic testing. Next slide, please. Okay, so we can't change those things, but what can we change? Lifestyle factors are hugely important. Tobacco use, alcohol use, being overweight or obese, and lacking physical exercise. And those are all things that all of us talk about with our patients in terms of improving their overall health. But of note, recently, we've known this for years, but it's really been highlighted recently that diets that are high in processed meats are now considered to be a significant cause of new cases of colon cancer. That combined with diet low in fruits and vegetables, a so-called low fiber diet, are really important in risk factors for colon cancer. And the idea is sort of this. Processed meats have carcinogens, nitrates, other things. If you have a low fiber diet, the carcinogens are going to have more time to be sitting in the bowel causing problems. So those two things combined can be very much a risk factor. Next slide, please. Symptoms of colon cancer. I think we all know this, but the population at large probably does not. In the patients who came to me, only one had blood in her stool. Having blood in your stool is something you don't like to talk about. And unfortunately, in the 90s, and even in the early 2000s, I think a lot of women were dismissed. Oh, it's a hemorrhoid. And the patients I had, and they were all women, their husbands had all had colonoscopies, sigmoidoscopies, and stool testing. Why had they not? They were embarrassed, or they felt that people weren't listening to them. I think having increased number of female practitioners in the population has really helped, made people more comfortable in coming forward and saying, I have a problem. So blood in or on the stool can be bright red, it can be dark. I had older patients who come to tell me they had dark stools, and one lady, she was in her 90s, said it's black. Unfortunately, her son decided that he didn't want to treat her. So that was very unfortunate. Other symptoms, change in bowel habits. So a stool can become very narrow, pencil-like. So somebody who used to have a normal stool will give you a history that, they're having a little trouble moving their bowels, and the stool is very narrow, pencil size. So dark brown or black stool, diarrhea, unexplained diarrhea in a patient who never had diarrhea, unexplained new constipation in a patient who never had constipation. Or in some patients, they'll present and tell you that they feel like they can't move the stool out of their rectum. And then you have concern, especially on the left side of the colon, for an obstructing lesion. Abdominal pain that is persistent. This is a very late symptom. If you have a patient who has abdominal pain, I would move them right away to a CAT scan because something's wrong. And I'm not talking about someone who comes in and has a little pain and moves their bowel, but somebody who's telling you they have abdominal pain that's getting worse, or any other symptoms like bloating or blood in the stools. Unexplained weight loss is very late. In both of those symptoms, you have a pretty advanced cancer. Next slide, please. Okay, and how does colon cancer start? I think we probably all know this, but the population at large does not. Typically, colon cancer starts as a polyp, an outgrowth of abnormal cells in the colon. Next slide, please. So typically, as I just said, it starts as a small growth in the lining of the colon or the rectum and can progress into a cancer. Common types of polyp, you'll hear this and you'll read this on reports of your patients. Hyperplastic polyps, those are little tiny polyps that generally do not progress to cancer. Tubular adenomas, which are what I see most commonly in my patients, and the so-called serrated sessile adenomas. These are becoming more popular, not popular, I should say, more prevalent. And unfortunately, these are a little harder to detect. These are the ones that cause the circumferential lesions that are much more common. They started being more common in Asian patients, and now we see them in the population at large. Okay, next slide, please. So I stole this from Sloan Kettering, but this is just a stepwise schematic of how colon cancer spreads. Stage 0, 1, 2, 3, 4. Stage 0 is when you're doing a colonoscopy and you find a small polyp, you remove it, and there's some abnormal cells, but it hasn't broken through the lining. Step 1 is where it's gone beyond the lining. Step 2 means you're going through the wall of the colon, but not into lymph nodes. Step 3, or stage 3, you've gone out of the colon into lymph nodes, and stage 4, this cancer has spread. Next slide, please. So this is a little cartoon which shows you basically how colon cancer starts. On the bottom of the left side, you can see that little cluster of green cells. That's stage 0. If you happen to do a colonoscopy and the gastroenterologist was fortunate enough to see this and biopsy it, that would be stage 0. The patients would still have to undergo resection because you don't know based on that biopsy what's going on. Stage 1, the cancer has broken through the lining called the mucosa and it's heading up towards the muscle layer. Stage 2, A, B, C, you can see it's progressing. Stage 2C, you're seeing it's breaking through the wall. And this is when the cancer starts to walk away and become metastatic. Next slide, please. And then these are the others. Stage 3A, we've gone through the muscle, cancer spreading through the lymph nodes. Stage 3B, it's getting very active in terms of spreading through multiple lymph nodes, and so forth. And then for stage D, I apologize, 4, can you go to 4? Next slide, please, I'm sorry. The colon cancer has spread to other parts of the body. Typically, where does colon cancer spread? Most commonly, it goes to the liver first, and that's because of lymphatic drainage from the colon and the rectum. After the liver, it can commonly be seen in the lung, can be seen in lymph nodes, can be seen all over the abdominal wall. Unfortunately, one of the symptoms of colon cancer in an advanced state is ascites. So you'll see patients with very enlarged abdomens full of fluid. It's not as commonly found, but it can also go to the brain and to the bones. Next slide. And so just a little show and tell. This is a patient actually who had 4 simultaneous colon cancers at the same time. On the left, you see that circumferential lesion. That's the sessile polyp, serrated polyp. Here in B, you see the polyp coming in through the top. And then C and D, these are the typical kind of polyps you'll see, and you see how it's a little ugly there on the side, and this one is hemorrhaging. So these are ulcerated polyps. When you see these, you're very suspicious that there's a cancer. I saved us from seeing some of the grosser ones, so I just want to give you a little taste of what colon cancer looks like. Next slide, please. Okay, so recently we've made great progress, and we have decided to encourage people to start screening for colon cancer. And I'm using colon cancer in place of colorectal cancer, but it's in the same group, by age 45. And this has been really helpful because, as I was speaking about my former patients, there were a number of them who we would never have screened just because of their age. They were under 50, they were asymptomatic. But a lot of them, they were in denial. So the easiest thing to do is a stool test, and we can do it in the office, which is a guaiac-based fecal occult. So you come in for an exam and we think you have a problem. We check the stool if there's blood or not blood. Most commonly, what we like to do is the fecal immunochemical test, the FIT test. In our clinic, we call it an IFOB. It's about $24. The benefit of this is no preparation. You don't have to change your diet. You don't have to hold your aspirin. You don't have to stop your Coumadin. And it can be done at home, brought back to the office, and easily processed. How often should you do this? Everyone should have this done every year. Drawbacks: you can have false positives. You can miss cancers. So just because your test is negative doesn't mean that you don't have a cancer. The guaiac test, which I spoke about, is pretty similar. The only thing is that it can have false positives depending on your diet or your medications. Lately, there's a test, has many names, of the one that I'm most familiar with is Cologuard, and that's a stool test that identifies 11 different biomarkers of altered DNA in colon cancer. It's about $550 without insurance, which is prohibitive to most people. How often should you do it? Every 3 years, and the same. I did not comment on virtual colonoscopy. I think that's really a waste of time, radiation, and money. If you're not comfortable doing colonoscopy, go for one of the better tests, but I still recommend colonoscopy as the gold standard for colon cancer detection. Cost, it's high. It's about $2,000. Most of us have health insurance that will cover it. It involves preparation, which typically involves not eating much except liquids for the day before your colonoscopy, and then taking a series of laxatives and bowel cleansers. I think most of us probably have had it done. I've had 6 for various reasons, my family history. It's not terrible. You can do anything for one day, especially if you have suspicion of having cancer and you're going to save your life. What is the benefit of it? Typically, you're going to see polyps, you're going to see cancers, and you can have biopsy and removal polyps that may be precancerous. And that's huge. You have a polyp that is sitting there, festering away, your gastroenterologist sees it, able to remove it. If it's removed wholly, you're done. Now, if you have a polyp that's precancerous, you will have colonoscopy in 1 to 3 years, depending on what they see. Typically, I don't see this as a reason for colon cancer screening finding that you have IBD, which is colitis or ulcerative colitis. But sometimes we do find that. Sometimes it's non-significant thing. I've had patients who've had biopsies that have shown non-caseating granulomas, which are common in Crohn's disease, which have not been significant in terms of them having the disease. Typically, for most people, you have a colonoscopy once, and you should have it done every 10 years. Next slide. Okay, and then this is the colon cancer survival rate. So if you have a colon cancer that's localized, and that would be stage 1 or 2, 0 or 1, your 5-year survival rate is 91%. The rectal cancer survival rate is very similar. I put them together here so you can just take a look at it. Regional means it's breaking through the colon, so you're going into the later stages of 2 or 3. Survival rate drops to 72%. Distant, so this is the metastatic disease. So you have it spread to your liver, to your peritoneum, to your brain, to your bones. Survival rate is only 13% for colon and 17% for rectal cancer. And this is your 5-year survival rate. And this does not mean that you're going to cruise along and one day before 5 years you'll fall apart. It's a progressive illness that's very difficult to handle. Overall, the prognosis is pretty good for colon cancer. It's about 63% for colon cancer and 68% for rectal cancer. If it's found and treated, obviously it's better. Okay, next slide. I think, oh, this is still me. Standard treatments, colon cancer is like many other cancers. The best thing to do is cut it out. You can cut it out. Often you are done. If it has broken through the wall or you have lymph node involvement, you'll be looking at chemotherapy. Radiation therapy is for more advanced cancers, and the others, the radiofrequency ablation, cryosurgery, targeted therapy, are also used for advanced cancers. And the immunotherapy is a new treatment with the monoclonal antibodies. And I haven't had enough patients have that lately, but I do know that's used for more advanced cancers. Next slide. Okay, Maggie, you're on, and Sonia.
Good morning, all. So what we did now is we just wanted to give you a little overview of what we do here at Parker. Of course, with Parker's partnership with the VNA through this New Jersey Seed program, it gives our patients the ability to be screened for colorectal cancer. As you can see, to qualify for the screening, they do have to be residents of New Jersey, 21 years or older, uninsured or underinsured, and has income less than or equal to 250% of the federal poverty level. And as Susie noted earlier, our patients definitely fall under that realm. The coverage services that are provided are for patients greater than 45. They'll receive a colorectal screening, and here we initiate that screening with the IFOB kit that we provide to our patients. And then under 45, if there's a medical necessity that is present, we would also provide them with the IFOB kits at that time. These are our steps that we usually will use, going from the provider initiating the screening. He or she will have the visit, and if they fall under the criteria, they'll initiate an order for the IFOB kit to be distributed. Sonia amazingly provides all of our patients with those kits and all the paperwork involved with the, such as the CAS forms that they need in order to be confirmed eligible, I guess would be, for lack of a better term. Once those kits are returned, they're tested by our clinical staff. If they're negative, we just put them in the chart, let the provider know they're available. If they're positive, we actually actively speak with them to let them know that they've been tested positive so that we can move forward quickly with the next step. And at that point, the clinician will usually order a colonoscopy. And all of that stuff between the results and the IFOB, the CAS forms, they'll get sent over for seed processing. Seed will allow us, for our patients that are qualified, a voucher that will be presented upon a colonoscopy testing. And personally, for our clinic this past year, we had 118 IFOB kits that were distributed. 104 of those were returned, which is an 88% return rate. We had providers order 18 colonoscopies, and they were performed, and thankfully there were no colon cancers diagnosed amongst that population. Yay. Yay.
And I just want to say, and I know Sonia will agree with me, the SEED program, I don't know if Natasha's on, Jenna, but her team, they are just wonderful partners. So we couldn't do this work without that partnership. So we're very, very, very grateful. And they make it happen. They're very creative. So we obviously, Parker offers a lot more services. We are the medical home to 1,200 folks. So we offer a lot of other services, starting to see children from ages 3 and up. But we wanted to focus on colon cancer today. So thank you, Jenna, for this opportunity.
Yeah, thank you, Jenna.
Thank you all. Wonderful presentation. And yes, Susie, feel free we have some time, if you wanted to talk a little bit more about some of the other, do a brief overview of some of the other services that you offered. I know you all just had a groundbreaking and an expansion. So that's some really exciting news. I'm sure the folks on the call would love to hear about it. If you're willing and you want to, it's a good platform. We welcome it.
Oh, great. Okay, so I'm always happy to talk about Parker, and I've got some of the team members here who can totally chime in if I forget anything. But we've lowered the age of our patients now to 3 years old. We have
5 PD,
Now we have 5
we-
pediatricians.
pediatricians who rotate coming to the clinic, all volunteers, small staff of 20, full-time and part-time, but we now have 82, we have 130 volunteers now, which has grown since the pandemic, and 82 of those are medical professionals. So we're really fortunate, and we've expanded our services recently to include on-site phlebotomy. And so patients who come here, they can come back here, or actually following a visit can get their blood drawn so that they're not missing more work. And all of that is free of charge through a partnership with Quest for Health Equity. And we're also providing mental health services on site, which is pretty awesome. And that's through a partnership with the Mental Health Association of Monmouth County. And we have on-site nutrition with a trilingual nutritionist, also through Monmouth Medical. And I mentioned Uber, but we also are providing eyeglasses free of charge. So we've been able to expand our vision program to not only it had been limited because we only had one ophthalmologist, and now we have 2 ophthalmologists and 2 optometrists. And so we've expanded our eye program to include everybody and children, which is pretty awesome because one of our optometrists has seen a number of children, and he said the kids don't even realize that they're not seeing properly, and when he puts the eyeglasses on them, oh, this is what it's supposed to look like. So that's great for school. And we also have pediatric dentists, Sonia. And that's the one thing we don't offer is adult dentistry, but we have pediatrics through age 14. And so we have a large portion of our population, and all of Lisa and Maggie can attest to this, that about half of our population suffers from some form of chronic disease, at least half, whether it's hypertension, hyperlipidemia, or diabetes. And we are very fortunate in that we have folks who are specialized in diabetics, a number of our nurse practitioners, and we also have an endocrinologist who comes on site, and a nephrologist. So we're very fortunate.
Pharmacy assistants.
Oh, thank you, Sonia. We do pharmacy. We also have a pharmacy assistance program, and last year alone, we distributed medicines at no cost to the patients, valued at $1.3 million. So, and last year, because we've expanded services, but also because, and I'm sure Jenna and the VNA team can attest to this, folks are sicker. This population has gotten sicker, whether it's as a result of the pandemic or they haven't been going regularly to the doctor for whatever reason. And we went from a little over 9,000 visits in 2021, and last year we had close to 16,000 visits in 2022. So I think it's a little of both. I think it's the expansion of the services, and also that we're providing more under one roof, but also I think that it's also due to the delay in getting treatment, and that we're seeing folks when they are just sicker.
COVID vaccines.
Yes, COVID vaccines, but I don't know if we'll still be able to provide COVID vaccines after May 11th. We're going to have to see how the ending of the emergency health. We'll have to find out how that impacts all of us. I think all of us are waiting with bated breath as to how that's going to impact us, because it will impact all of us.
We do COVID testing.
Yeah. Yes, we also do COVID testing. Okay, Lisa, Sonia is a walking reminder of everything we offer.
We need her.
We do need her.
100%.
Maggie, Lisa, Sonia, did I leave out anything?
I don't think so.
I'm going to stop the share.
I have so many questions. I'm sure there are others here. So I see a lot of our seed partners who you mentioned. So big ups to them. But I also see some of our other partners in the community that would be able and willing to refer the families that they respectively work with to your programming. So you mentioned so many great and comprehensive services. How do you get funding for all of these things, Susie? Especially knowing that you are offering so everything that you do, so affordably to the families that they're able to take advantage and you're able to serve so many.
We get our funding through donations and through grants, and also through partnerships. I'm a firm believer that if somebody else is doing this really well, I don't need to hire that person or start a new program. So that's why we partnered with the Mental Health Association of Monmouth County. They know how to treat mental health. They know therapy far better. So why start a new program? They just come on site, and their bilingual therapist is here 2 evenings a week, and it's wonderful. And the same with the nutrition program. Monmouth Medical has that beautiful wellness center out by the mall, and they are doing this work. So their nutritionist comes twice a week. And for everything else, I really look for funding. I mean, we are not a line item in the federal budget. We don't have any guaranteed source of funding. That's the bottom line. We start every January, which is our fiscal year is the calendar year. We start every January at zero. There's no guaranteed source of funding. So come January, I have a slight panic attack, and then we work through it.
Yeah, no, I'm glad that you said all that you did, because I think it's important for this group to know, how valuable the partnerships in the community are. And that, if somebody here has a contact that can help push along the services and support the services that Susie and team were sharing, that can go a long way to continue to help these families. The other one thing that's kind of like a question/comment is that, of course, our coalition works with people in Monmouth and Ocean County. And so I'm wondering, Susie, as far as target area, do you see people that are coming to you from other areas? I know Monmouth County, but Ocean County particularly, because I don't know that they have anything like this in Ocean County.
They have a much smaller clinic, and I am noodling the idea of in the long range plans of figuring out how to expand their services by joining forces. But right now I need to get through the building. So we're moving forward to expand our space because we've expanded our services, and we realized that, having therapy and nutrition classes in the exam rooms really was not conducive to lowering people's anxiety, because I, for one, as soon as I hear the crinkly white paper, I get anxious. And so I think that when you see the nutritionist spreading out the pretend food on the exam table, it's not, so now we'll have space for all of that. So it will be really fun. And our phlebotomist shares space with the server, our computer server. So we need to expand, we need to have room for this. So, and any of you who have visited, I know Natasha's been here, I know Kathy's been here from the beginning. You can attest to the fact that we need a little bit more space.
Yeah, I mean, there's never enough space for all the great work you're doing. So thank you for sharing all about it. I would like to open the floor up to other people who might have questions. There's so much great information offered here today. Does anybody have questions for the team?
I'm sorry that I'm late. This is Victor.
Hi, Victor.
I decided to pop in really quickly because it's very busy where I'm at right now. And if you guys don't mind, I would like to share my information briefly. The intent was to be in the meeting all day, but a couple of clients are in need of services, so I can't stay for long. But I appreciate you all. My name is Victor Peralta. I work for Fulfill, and you heard of Fulfill. We are the one of the food banks here in Monmouth County in Ocean, and my role is the Resource Connections Manager. And one of the things I do and my team of 5, we actually do SNAP applications, we do health applications, and a couple of other referrals pertaining to that particular client's needs. So I don't know if you come across that in your agencies. If you do, I'll give you my direct number where you can link any client or any information that you're looking for. You can actually call me directly. I'll give you that information right now. Give me a second. You can actually call me directly at 732-272-47112. And the general number that you can issue to clients is 732-918-2600. We speak Spanish. We are actually working a lot with the undocumented children as far as health, because they qualify. So I will appreciate any referrals that you may have or any questions that you may have. Don't hesitate, just call the number, especially the personal one that I gave you. That's my direct number. So you're privileged because I gave you my direct number. And do not hesitate. Any questions that you have, just go right ahead and call me. Just like the movie, Call Me, like when Harry met Sally, just call me, that one. But anyway, Gina's gonna ban me from these meetings, right?
No, not at all, not at all. Your message came at a nice time. We were just about to go through the Q&A session. So thank you for offering your services. Fulfill has been a wonderful partner to us. So if it can benefit others here on the call, that's wonderful. Thank you.
And thank you for including me in your meetings, Gina. It's very important. And I love the fact that you are so proactive, and I appreciate you, standing a hand to allow me to communicate myself with your group. You're doing wonderful things, and thank you for that. I apologize to the entire group today because we're very busy. I wasn't expecting it to be busy. We have a couple of people that are off site. Again, the intention was to stay the whole day, but I apologize for that.
Don't worry about it. You know what, if you could just put your contact information again into the chat for everybody. This way they have it written down and we can take it.
I'll do it right now.
Okay.
I'll do it right now. You know how that goes. Things change all the time.
Yeah, if you don't do it now, forget it. Diana, you had into the chat box before about the vaccine. So I just want to give you the platform to mention that. I didn't see the message until recently.
Yes, thank you, Jenna. No, it's fine. So Parker, the staff at Parker had mentioned that the COVID vaccines, they may not be continuing to give them out. I do want to remind folks that VNA still does provide COVID vaccinations every week at multiple locations. If anyone is interested, you guys can reach out to me. I did put in my contact information, but I'll put it again. So I can provide you with the weekly schedule of where those vaccinations are being offered every week. As far as I know, we're still going strong with that. We do have some regular locations that we go every week to set the same locations, but we can also provide it privately if anyone would like to host a vaccination party, a vaccination session. But I do want to comment that this presentation was so needed and wonderful. Dr. Herx, thank you so much. The information was wonderful. You did a great job of scaring me a little bit, but that's your job. That's your job. You're supposed to do that. No, you put the fear in people sometimes, and that's what motivates them to get in. And if that's what happens, then that's what needs to get done. And I'm happy for that. I've had a colonoscopy done. I had it done, I believe it was in my 30s. And they told me I had like small, tiny tears that can form pockets. So that helped me know that I needed to eat more fiber so that I wouldn't get irritations, stomach problems or intestinal problems. And that has kept me on the straight and narrow. But it's time to get another one. So you have motivated me. I will surely get one done within the next 30 days. So thank you.
Oh, thank you. Well, the good thing is those tears are diverticuli, and they don't generally predispose you to cancer.
No, but it's important to know for me that I've had those tears.
Totally, because then you can change your diet and prevent complications.
I
Yeah,
did.
that colonoscopy, it's really not bad.
No, it's
Me,
bad at all.
stop at the diner on the way home and have a nice breakfast.
Yeah, you're right. That's a good point.
Diana, just to clarify, we're still going to be doing the vaccine. It's just very unclear what is going to happen with the uninsured.
Yes, so
What the access is going to be like. What I am hearing is post May 11th, there is still going to be supply. So as long as there's supply and we will have, I've been assured we will have access to it. We will continue to offer therapeutics. We will continue to do everything that we've been doing in the community for the uninsured. It's just a question mark as to how long that is going to continue. And anyone who's watching this, I think it's a question mark for everybody, because even for insured people, how that's going to be covered is a question mark post May 11th.
yeah.
I think that's for everybody.
I agree. But you know, we always partner together. We're so great partnering together. So if anything should change, we can always work with our nurses to come together and provide what we have and share the wealth. I mean, why not? That's how we cooperate so greatly in the community.
And Diana, thank you. I've been emailing with you, Sonia, about transportation for our patients.
Yes.
Yes. Thanks to you. It's been on the
Sonia,
call.
so nice to meet you. Your 4 people are all set, by the way.
Thank you. Yes. Thank you. Thank you.
Oh, this is wonderful. I saw a couple people take themselves off, put themselves back on camera, which makes me think they might have something to share or a question. Does anybody else have a question?
Hi, good morning, everyone. It's Aiden. Hi, how's everyone doing? This is Mariela Flores. I did have two questions for Parker Family Health Center. One is, you had mentioned the Uber's transportation. How far of a distance, like, is there a limit to the distance wise of that you're providing that service for folks that want to go to your facility? And do they have to be an established patient first to have access to that? Or like, can it be for an initial person trying to get there?
So hi, Mariela, it's Susie. We offer that service anywhere in Monmouth County. And we also, it can be for an initial visit. We have done that because there is an initial visit, because there's an intake. And if, depending on the severity of the case, we will also, for example, we've had people who are discharged from the hospital. We do the intake and get a visit right then and there, you know, depending on how quickly the person needs to be seen. So it is on a case-by-case basis. But to answer your question about transportation, it's anywhere in Monmouth County, and it is it can be for an initial visit.
Okay. And then my second part, thank you for that. Second part to that, I missed the beginning of your presentation. So like where you were explaining some of the services, like what do you have to do to get in for services? So my question was, with the new law, with the new children, undocumented children being able to have access to NJ Family Care, would a child that is in that process still qualify to be able to be seen at your facility?
I didn't hear.
She's saying that if they qualify for the new program and without the undocumented, could they still come here if they chose not to do that?
Yes, they can still come here. Thank you, Maggie. Yes, they can still come here if they have chosen not to do that. Yes.
Okay. Thank you.
And there are folks opting out of that. And also what's nice, Mariela, is that the entire family can come.
Yes, thank you. And I already have like 2 families that I'm going to be sending your way. So thank you.
Well, here, I can put in the chat, if I can find the chat. I'll put in the chat my cell phone number, and you can just give me a call and we'll get them in. Okay?
Thank you.
Wonderful. New patients gained, new resources to be shared. Any other questions for Parker Family Health Center team?
Hi, I'm Lady Garachi from Mammoth Medical. I do have a question. Hold on. Here it is. Okay. So I didn't hear quite about the mental health. She was saying that she has, they have counselors that are bilingual. Is that a Spanish person? Because we do have a lot of, referrals for counseling, but they really, like, it's very hard to find a counselor that speaks Spanish. So do you have anybody in staff that can?
Yes, our counselor, our therapist is bilingual.
Okay, great. Any of this is a Spanish speaking, and or do you have any other languages or just the Spanish one?
Right now, just Spanish.
Okay,
And
thank
English,
you.
well, Spanish and English, yes.
Okay. All right.
Anybody else have any other questions they want to ask for the team? Okay. All right. So Susie put her information into the chat box. So if anybody feels more comfortable reaching out directly, I'm sure that's welcome. We would love to thank the Parker Family Health Center team again for presenting on our Health to Hold webinar series. As I mentioned in the beginning, we do this once a month. It's on a Wednesday. The next one happens to be on Wednesday, April 26th. It's going to be with the Rutgers Cancer Institute of New Jersey team, and they will be helping us recognize National Minority Cancer Awareness Month. So we're looking very forward to that. It's at 10 a.m. and you'll be receiving some communication from me in regards to how you can join us for that. And we just thank you so much for the opportunity to work together and to continue to serve Monmouth and Ocean County together. So thanks again, everybody, and have a wonderful day.
Thank you, everybody.
Bye-bye.
Bye.